Hi everybody, this is part 2 of our acute thorax series, and in this video we're going to go over the answers for the cases presented in the prior video. So this was our first case, chest radiograph, and here we can see an example of pneumomediastinum. We can see these linear lucencies extending along the contour of the mediastinum and into the neck, especially at the base of the neck over here. The heart is normal in size. There's no evidence of pneumopericardium. We don't see a continuous diaphragm sign. We don't see a pneumothorax. The lungs are pretty clear, and I'm just going to glance quickly, but I don't see any rib fracture. Maybe this may be a rib fracture, but it would be difficult to say for sure with just these views. So pneumomediastinum. Depending on the cause of the pneumomediastinum, it may warrant further workup, or the patient might be able to go home. Usually if this is, a younger patient, active patient, otherwise healthy, and they have incidental pneumomediastinum, then the management is very conservative and the patient can just go home. If this were a case of maybe a patient who was vomiting and retching excessively, this could be evidence of Boerhaave syndrome, and that could warrant additional studies and potential emergency surgery. This is a lateral chest radiograph, and the pertinent finding here is this little curvilinear lucency along the heart contour. And this is the oreo sign, or the sandwich sign, and it signifies a pericardial effusion. Here, this opacity, this is the heart. This little curvilinear lucency represents the epicardial fat, the pericardial fat, and this over here is the fluid within the pericardial cavity. This is a pericardial effusion. This is a CT thorax lung window, and we see a large defect in the right lateral chest wall. We see all this gunk in the right thorax and some patchy confluent airspace disease in the left thorax. This is an example of an LOS or flap. This is not an acute case. I told you in the prior video that 2 or 3 of these would not be acute, and this is one of the treatments for pleural empyema secondary to tuberculosis is usually the history here. And the reason we do this, or the reason this might be done, is because if somebody has an infected pleural fluid, or an accumulation of infected pleural fluid, that's not readily treatable with antibiotics, and sometimes just putting in a chest tube to drain it doesn't work because the tube can get clogged from the pus or the thick debris, and the tube can cause other complications. Usually it's just not very effective in draining the infected fluid, so they form this communication, this fistula between the infected pleural cavity and the cutaneous surface to allow for more effective draining. This would be subsequently closed up after all of the infection would be cleared. Okay, we have a scroll through case here. And this is a little hard to pick up, but we have a little bit of some soft tissue, abnormal soft tissue density posterior to the sternum. And maybe if I can convince you that there might be a little bit of a cortical step off here. The clincher is in the sagittal view, where you can see these minimally displaced sternal fractures. So this is an example with sternal fracture with a little bit of hemorrhage into the anterior mediastinum. Okay, this is an intramural hematoma, pretty extensive. You see the aorta here, and we see this kind of soft tissue thickening along the aortic wall. And what gives this away are these intimal calcifications. And if this was, regular atherosclerotic disease, the intimal calcifications should be along the wall over here. But this is an example of displaced intimal calcifications, and this is seen in intramural hematoma. We can also see maybe over here that there's a little blood pool of more acute appearing blood right here, so intramural hematoma. Another scroll through case, and again we have some small pleural effusions bilaterally, but the main finding here is this hyper attenuating or hyperdense or bright curvilinear material along the aortic wall. And this is again an example of intramural hematoma. Okay? And the reason, if you are ever expecting a dissection or intramural hematoma, then you need to do a CT thorax without and with contrast. Because if you do the exam with contrast, you may miss this. Okay, we have another scroll through case. And so here we see a pretty abnormally positioned heart into the left hemithorax. And the patient had another imaging exam just a few days later. And again, we see that the heart is somewhat displaced towards the left, but to a different degree compared to the prior exam. This is a non-acute case, and this is an example of congenital absence of the pericardium. Basically, you have all these connective tissues around your heart, which, connected to the vessels superiorly, connected to the sternum anteriorly, and when these structures are absent, and in this example the pericardium is not well held in place and can move a little bit. We have another scroll through case here, and in this case we have an example of an aortic pseudoaneurysm, and the finding is right here. We can see sternal fracture here, some soft tissue injury, and we can see that there is this little bit of extravasation of blood from the ascending aorta, from the aortic root into the mediastinum over here, and this blood has extended through all layers of the aorta, so it's not an aneurysm, it's a pseudoaneurysm, and the blood is collecting within the mediastinum. So this is a traumatic pseudoaneurysm. Single slice CT thorax lung window. The finding here is a wedge-shaped consolidation, and that should tip you off for a pulmonary infarction, and that's usually seen in the setting of a pulmonary embolus. We'll go to our contrast enhanced window, and we can see here a central filling defect within the respective pulmonary artery consistent with acute pulmonary embolus. Okay, this is an example of a normal finding, which can often be confused with a abnormal finding. This is an example of a ductus diverticulum. This is, because of its size, it can be a little confusing with the other condition you'd see here, which would be a pseudoaneurysm or acute aortic injury. But the reason you know that this is a ductus bump is because there's some calcification here without any significant calcification elsewhere. So calcification means it's chronic, and this is a ductus diverticulum, a normal variant. Some other clues to know that this is a normal variant rather than pathology is that usually the angles are not so acute. Now, because this one is particularly large, the angles tend to be more acute, and it can be a little bit confusing, but usually when they're less prominent, the angles are more obtuse rather than acute. A third way, or a third clue, is to look for any evidence of other nearby injury. So if I saw this and then the patient had a large mediastinal hemorrhage, then it would help me lean towards a acute aortic injury rather than a normal variant. So this is an example of a normal, or a more normalish appearing ductus diverticulum, and we can see here just at the aortic isthmus distal to the origin of the subclavian artery here. This is a more typical appearance of the ductus diverticulum, a normal variant. Our next case was this finding over here, and this is an example of lung herniation through the intercostal muscles. Now, this could be an acute finding, or it could be a non-acute finding. The concern here, not so much in this one because it's such a wide neck, but if the neck is a little smaller, then there is a potential for herniated lung to become incarcerated and eventually strangulated and infarct. We have another scroll through case. Okay, and really the best way to make the diagnosis here is on the coronals, and this was a case of trauma, and this is a case of traumatic diaphragmatic rupture with herniation of bowel into the left hemithorax. You can see that bowel from the abdomen is continuous into the hemithorax, and we can see that here's the diaphragm, and it ends over here and starts over here. Compare that to the normal diaphragm over here. I think we have two more cases. So chest radiograph, and the finding here is this pattern of calcification. And this is a case of intramural hematoma, and again, these are displaced intimal calcifications due to intramural hematoma. So it's a nice way to pick up this diagnosis on a chest x-ray. Oops. Our last case here, another CT thorax lung window, and the arrows help out, but it's a pretty obvious finding, and we can see some consolidation or some increased opacity in the lung here, and we see this swirling. So this is an example of lung torsion, and this could be congestive edema, could be hemorrhage, or it could be active ongoing infarction. So those are the answers for the cases in my acute thorax series. Let me know how you did. If you liked the video, give it a thumbs up, and if you want to see more of these, then subscribe to the channel. I'll probably be doing an acute abdomen and an acute head series at some point as well. Anyways, thanks for watching.